Good morning, everyone. Welcome to the presentation. The topic is autoimmune encephalitis. Autoimmune encephalitis refers to a group of neuropsychiatric disorder caused by antibodies directed against neuronal cell surface or synaptic antigens. It is now recognized as one of the most common causes of non-infectious encephalitis. Unlike classical paraneoplastic syndromes, these antibodies directly interfere with normal neuronal signaling and synaptic transmission, thereby leading to a wide spectrum of neurological and psychiatric manifestations. Autoimmune encephalitis may occur in association with an underlying malignancy, but many patients have no detectable tumor. The disease can affect individuals of all the age groups, although it is more commonly seen in children and younger adults. An important characteristic of this disorder is that neuronal dysfunction is often reversible and most of the patients show significant improvement with early initiation of the immunotherapy. Among the various subtypes, anti-NMDA receptor encephalitis is the most extensively studied and most frequently recognized form of autoimmune encephalitis. So, in autoimmune encephalitis, autoantibodies bind to the neuronal cell surface protein or synaptic receptor that are essential for normal neuronal communication. This interaction disrupts the receptor function and synaptic transmission, resulting in neurological and psychiatric symptoms. Importantly, the underlying mechanism is predominantly a functional impairment of the neuronal activity rather than irreversible neuronal destruction or the cell death. Because the antibodies alter the receptor function without causing significant structural damage, their effects are potentially reversible. With timely diagnosis and appropriate immunotherapy, many patients will experience a gradual recovery, although the recovery process may be prolonged and may take several months. The neurological outcome is often substantial, and in many cases, it is near complete. So, this autoimmune encephalitis is caused by antibodies against neuronal surface antigen, leading to reversible neuronal dysfunction and a good response to immunotherapy. It may occur with or without associated malignancy. In contrast, classical paraneoplastic encephalitis involves antibodies against intracellular neuronal antigens with a T cell mediated neuronal injury and is strongly associated with a cancer. So, it will cause irreversible neuronal damage and responds very poorly to the immunotherapy. Intracellular onconeural antibodies and synaptic receptor antibodies present two distinct forms of autoimmune encephalitis with important difference in the pathogenesis and prognosis. Intracellular antibodies such as HU, RI, YO, MA2, and CRMP5 typically affect older adults and are strongly associated with the underlying malignancy, and they target the intracellular neuronal proteins. The disease is primarily mediated by cytotoxic T cells, resulting in irreversible neuronal damage, poor response to immunotherapy, and limited monophasic and limited recovery. It has a low risk of relapse because the illness is usually monophasic. In contrast, the synaptic receptor antibodies include NMDAR, AMPR, GABAR, LGI1, Caspar2, glycine R, can occur at any age and have a weaker association with the cancer, and they target the neuronal surface receptors. These disorders are caused by direct antibody mediated receptor dysfunction. They respond well to the immunotherapy. They achieve a major or complete recovery in approximately 75 to 80% of the patients, and they have a higher rate of uh, relapse risk in around 10 to 25% of people, emphasizing the need of long-term follow-up for these cases. Let us understand limbic system. Limbic system is a network of interconnected cortical and subcortical structures. It regulates emotion, memory, motivation, learning, behavior, and autonomic endocrine responses. It links higher cortical function with the hypothalamus or the brainstem. The image shows limbic lobe medial view showing cingulate gyrus, temporal lobe, amygdala, hippocampus. So the major component of this limbic system are cortical structures like cingulate gyrus, hippocampus, parahippocampal gyrus, entorhinal cortex, the subcortical structures like amygdala, hypothalamus, septal nuclei, anterior nucleus of thalamus, nucleus accumbens. Clinical importance. Autoimmune limbic encephalitis is associated with memory loss, seizures, behavioral changes. Alzheimer's disease associated with early hippocampal atrophy. Temporal lobe epilepsy is due to involvement of hippocampus and amygdala. Kluver-Bucy syndrome is due to bilateral amygdala lesions causing hyperorality, hypersexuality, and placidity. Wernicke syndrome due to mammillary body damage. Depression, anxiety, PTSD due to dysfunction of amygdala, hippocampus, and cingulate cortex. A viral prodrome is commonly seen in patients of autoimmune encephalitis. This precedes the onset of neurological symptom by 1 or 2 weeks. Patients typically present with non-specific symptoms such as headache, fever, lethargy, upper respiratory tract symptoms, nausea, diarrhea, resembling a self-limiting illness. Recognizing this prodromal phase is clinically important as it can provide an early clue to the diagnosis when followed by characteristic neuropsychiatric manifestations of autoimmune encephalitis. So, the autoimmune encephalitis typically presents as a rapidly progressive encephalopathy with symptoms evolving over days to weeks. Common clinical features include memory impairment, behavioral changes, cognitive decline, psychosis, seizures, and various movement disorders, although a single symptom may predominate during the initial few stages. Because of its diverse presentation, the condition can closely mimic viral encephalitis or primary psychiatric disorder. The first step in evaluating suspected autoimmune encephalitis is to exclude the infectious encephalitis, particularly herpes simplex encephalitis, as delayed treatment can be life-threatening. Diagnosis requires integration of clinical features, laboratory investigations, MRI findings, EEG, and antibody testing. However, clinical judgment remains the most important component of the diagnosis. Autoimmune encephalitis should be suspected in young patients with rapidly progressive encephalopathy, new onset psychiatric disorders, seizures, movement disorders, and a negative infectious evaluation. Early diagnosis and treatment are crucial for the favorable outcome. Possible autoimmune encephalitis requires three components. First, a subacute onset of cognitive, behavioral, psychiatric, or consciousness changes developing within a period of 3 months. Second, at least one supportive feature such as focal neurological deficit, unexplained seizure, CSF pleocytosis, or MRI evidence of encephalitis. And the third, exclusion of alternative diagnosis. All three criteria must be satisfied to establish the diagnosis of possible autoimmune encephalitis. Coming to definite autoimmune limbic encephalitis, it is diagnosed when there is a subacute onset of memory impairment, psychiatric symptoms, seizure developing within a period of 3 months, along with MRI evidence of bilateral medial temporal lobe involvement on T2 flare sequences. Supportive evidence is provided by either CSF pleocytosis or temporal lobe abnormalities on EEG, and alternative diagnosis must be excluded. Fulfillment of all the four criteria establishes the diagnosis of definite autoimmune limbic encephalitis. The alternative causes that need to be excluded are infectious meningoencephalitis, septic encephalopathy, metabolic encephalopathy, toxic encephalopathy, Hashimoto encephalopathy, Creutzfeldt-Jakob disease, cerebrovascular accident, intracranial neoplasms. The role of antibody testing. If one of the major criteria for definite limbic encephalitis is absent, the diagnosis can still be made if the neuronal surface or synaptic or onconeural antibody is detected. Antibody testing should include both serum and CSF, as testing both increases diagnostic sensitivity. This is especially important in anti-NMDR encephalitis, where about 14% of CSF positive patients are CSF positive despite negative serum antibody levels. Therefore, both CSF and serum should be tested in every suspected case of autoimmune encephalitis. Antibody titers. CSF antibody titer correlates better with disease severity and disease activity than serum antibody levels. Serum titers often correlate poorly with the clinical status, and usefulness of antibody titer for monitoring recovery is uncertain. Therefore, clinical assessment remains the most reliable method for evaluating disease progression, treatment response, and prognosis in autoimmune encephalitis. Tumor screening. This is important because several autoimmune encephalitis syndromes are associated with underlying malignancy. Identifying and treating the tumor improves the neurological outcome and reduces the relapse risk. Initial screening typically includes CT of the chest, abdomen, and pelvis to evaluate the pulmonary, abdominal, genitourinary malignancies such as small cell carcinoma of the lung and ovarian teratoma. Additional tumor screening in women includes gynecological examination, that is, gynecological examination and breast imaging and ovarian ultrasound and a pelvic MRI if indicated. It is to primarily detect ovarian teratoma and breast malignancy. In men, the testicular ultrasound is initially done, uh, and if suspicion of malignancy persists, whole body FDG PET scan should be considered to identify the occult tumors. The key principle in autoimmune encephalitis management is not to wait for the antibody result before starting the immunotherapy. The immunotherapy should be initiated based on strong clinical suspicion after excluding infectious causes. Early treatment significantly improves neurological outcome and therapy can be later modified according to the antibody result and clinical response. If an underlying malignancy is identified, tumor resection should be performed whenever possible, along with appropriate chemotherapy and radiotherapy. Treating the tumor accelerates the neurological recovery, improves the response to immunotherapy. It reduces the relapse risk and leads to better long-term outcomes. In paraneoplastic autoimmune encephalitis, oncological treatment is critically important for overall management. Coming to anti-NMDR encephalitis. Anti-NMDR receptor encephalitis is the most common antibody-associated autoimmune encephalitis, and it is the second most common immune-mediated encephalitis after acute disseminated encephalomyelitis. It is caused by antibodies directed against the GLUN1, also known as NR1 subunit of the NMDR receptor. The disease predominantly affects young women, children, and nearly 80% of the cases occurring in these groups. However, it can also occur in men and elderly individuals also. This anti-GLUN1 antibodies cause internalization and loss of NMDR receptors, leading to impaired synaptic transmission. Since this process is reversible, many patients show substantial recovery and immunotherapy. With immunotherapy, the diagnostic gold standard is by the detection of anti-NMDR receptor antibodies in the CSF, which is more sensitive and specific than the serum testing. The median age of onset of anti-NMDA receptor encephalitis is approximately 21 years. It most commonly affects children, adolescents, and young adults, particularly young women. Around 38% of these patients have an associated malignancy, with ovarian teratoma being the most frequently identified tumor. The tumor association is seen more commonly in adult females and is relatively uncommon in children and in male patients. So, anti-NMDA receptor encephalitis, it begins as a viral prodrome, that is, a prodromal phase characterized by viral-like illness with symptoms such as fever, headache, malaise, upper respiratory symptoms. This is followed by psychiatric phase during which patient develops acute psychosis, agitation, anxiety, hallucinations, delusions, behavioral changes, and mood disturbances and insomnia. In many adults, these psychiatric manifestations are prominent enough that the patient are initially admitted under psychiatric services for these complaints. As the disease progresses, the neurological phase develops. That is, patient may develop seizure, memory impairment, reduced level of consciousness, speech dysfunction, and catatonia. This is often followed by development of characteristic movement disorders including orofacial, limb, and truncal dyskinesia. In children, anti-NMDA receptor encephalitis commonly presents with movement disorders, behavioral changes, new onset seizures, insomnia, and reduction of speech output. During the later stages of anti-NMDA receptor encephalitis, patients frequently develop autonomic dysfunction, which may manifest as tachycardia, bradycardia, blood pressure fluctuations, hyperthermia, hypersalivation, and cardiac arrhythmias. Severe cases can progress to central hypoventilation, often necessitating prolonged mechanical ventilation and intensive care support. As illustrated in the disease course, here, neurological complications such as movement disorders, dysautonomia, hyperventilation, seizures typically occur during the period of maximum disease severity before the gradual recovery develops over months to years. So, anti-NMDA receptor encephalitis can occasionally present as partial syndrome with isolated psychiatric symptoms, predominant movement disorders, or mild phenotypes. However, most patients eventually develop multiple components of the characteristic syndrome over time. Atypical manifestations such as cerebellar ataxia, hemiparesis may also occur and more frequently observed in children than in adults. Tumor association is an important feature of the disease, particularly in adult women. Ovarian teratoma is the most common associated neoplasm, and it is identified in approximately 40% of the women older than 18 years. Rarely associated tumors include mediastinal teratoma, small cell lung carcinoma, Hodgkin's lymphoma, neuroblastoma, breast carcinoma, and testicular germinal cell tumors. The CSF analysis is abnormal in majority of the patient with anti-NMDA receptor encephalitis. The typical findings include lymphocytic pleocytosis seen in approximately 80% of the cases, along with a mild elevation in the protein and presence of oligoclonal bands. MRI images of the brain is normal in most of the cases, with MRI typically demonstrating T2 or FLAIR hyperintensity involving the cerebral cortex, basal ganglia, brainstem, or limbic structures. Less commonly apparent findings are mild and transient contrast enhancement and meningeal enhancement. So in this image, we can see a 61-year-old male patient presenting with confusion. These two T2 MRI sequences, axial and coronal sequences. Here we can see bilateral temporal and hippocampal hyperintensity indicative of autoimmune limbic encephalitis. So EEG is abnormal in approximately 95% of these patients with anti-NMDA receptor encephalitis. The most common finding include diffuse slowing, generalized slow activity, disorganized background rhythm, and focal slowing, while electrographic seizures may also occur in some. A characteristic EEG pattern known as extreme delta brush is seen in approximately 10 to 30% of these patients. This pattern resembles delta brush seen in premature neonates and is considered highly suggestive of anti-NMDA receptor encephalitis. Its presence is associated with a severe form of the disease, prolonged hospitalization, delayed recovery. Therefore, the identification of the extreme delta brush pattern in patient with unexplained encephalopathy should strongly raise the suspicion of anti-NMDA receptor encephalitis. So this EEG demonstrates characteristic pattern of extreme delta brush, which consists of generalized rhythmic delta slowing with superimposed fast beta activity, producing a serrated or a brush-like appearance. This pattern resembles the delta brush seen in premature neonates and is considered highly characteristic of anti-NMDA receptor encephalitis. The presence of extreme delta brush is associated with a more severe disease, prolonged hospitalization, and delayed neurological recovery. So here we can see extreme delta brush. So there is a delta wave. So these are delta waves, and we have brush-like appearances here, superimposed beta waves. Here also we can see this is how delta waves appear, and these are the delta waves, and upon that there is a superimposed beta activity, which gives appearance of extreme delta brush. Coming to anti-GABA B receptor encephalitis, This is an autoimmune encephalitis characterized predominantly by the limbic encephalitis and severe seizures. It typically affects older adults with a median age of around 62 years and occurs equally in men and women. More than half of the patients have an underlying small cell lung cancer neurological symptom, and the neurological symptom often appear before the malignancy is diagnosed. Therefore, recognition of this syndrome should prompt an active search for the occult malignancy in a patient. In anti-GABA B receptor encephalitis, autoantibodies target the GABA B receptor on the neurons and act as a functional antagonist. Unlike anti-NMDA receptor encephalitis, the antibodies do not cause the receptor internalization. The resulting loss results in loss of GABAergic neurotransmission, leading to neuronal hyperexcitability, which manifests clinically as seizures and limbic encephalitis. The MRI brain is abnormal in approximately two-thirds of these patients and typically demonstrates unilateral or bilateral medial temporal lobe T2 flare hyperintensity, reflecting the characteristic pattern of limbic encephalitis. EEG commonly shows temporal lobe epileptiform discharges and focal slowing. Subclinical seizures are frequent, and in some patients, EEG may reveal non-convulsive or convulsive status epilepticus. Here we can see hyperintense signal involving the bilateral median temporal lobes, predominantly involving the hippocampi and amygdala. Findings are characteristic of the limbic encephalitis. Here we can see intermittent or continuous delta or theta slowing activity over the temporal regions, which may be unilateral or bilateral. CSF analysis typically shows a mild lymphocytic pleocytosis with a modest elevation in the protein levels. Detection of anti-GABA B receptor encephalitis, anti-GABA B receptor antibodies in the CSF confirms the diagnosis. Patient may also harbor additional autoimmune antibodies such as TPO, ANA, GAD65, while paraneoplastic antibodies include SOX1, ampifycin, RI antibodies may also coexist, particularly in those with an underlying malignancy. The small cell lung cancer is the most common associated with the anti-GABA B receptor encephalitis and is present in more than half of the detected patients. Therefore, cancer screening is essential in every patient diagnosed with this condition. Diagnosis is based on the clinical feature and of limbic encephalitis, characteristic MRI findings which involve the medial temporal lobes, and also EEG evidence which shows temporal lobe seizures, and CSF analysis and confirmation is with the GABA B receptor antibody level in the serum or the CSF. Anti-GABA B receptor encephalitis typically presents as limbic encephalitis with memory impairment, confusion, behavioral changes, prominent seizures. Seizures usually originate from the temporal lobe and may progress to secondary generalized seizures or even status epilepticus, while subclinical seizures are frequently detected on EEG. Rarely, patients may initially present with cerebellar ataxia or opsoclonus myoclonus syndrome, but these manifestations often evolve into classical picture of limbic encephalitis. Anti-AMPA receptor encephalitis. It is also an autoimmune encephalitis caused by antibodies against AMPA receptors. It typically presents as limbic encephalitis. So, patients commonly develop memory problems, confusion, behavioral changes, seizures. An important point to remember is its strong association with the cancer, making it a frequent paraneoplastic autoimmune encephalitis. Epidemiologically, it mainly affects middle-aged and older women with a median age of around 62 years. About 60% of these patients have an underlying tumor. So, screening for malignancy is essential part of the evaluation. In anti-AMP receptor encephalitis, the antibodies mainly target GLU-A1 and GLU-A2 subunit of the AMPA receptor. When these antibodies bind to these receptors, they cause the receptors to be internalized and removed from the neuronal surface. Brain then tries to compensate by inserting GLU-A1 homomer receptors into the synapse. However, these replacement receptors increase the synaptic excitability, which is believed to contribute to seizures and other neurological symptoms seen in these patients. The typical presentation of anti-AMP receptor encephalitis is a subacute limbic encephalitis with the symptoms developing over less than 8 weeks. Patients commonly present with confusion, disorientation, and prominent memory impairment due to involvement of the limbic system. Some patients may have a broader clinical picture with limbic dysfunction associated with multifocal or diffuse encephalopathy. Psychosis can also occur but is relatively uncommon. Seizures are seen in less than half of these patients and less frequent when compared to GABA B receptor encephalitis, where seizures are often the dominant feature. MRI brain usually is abnormal, and in this anti-AMP receptor encephalitis typically shows flare hyperintensities involving medial temporal lobes consistent with limbic encephalitis. Occasionally, transient flare signal changes may also be seen in other regions of the brain. On electroencephalogram, temporal lobe epileptiform discharges may be present and focal slowing is commonly seen. However, EEG findings are generally non-specific and mainly support the diagnosis rather than confirming the diagnosis. Here we can see MRI flare image demonstrating hyperintense signal abnormalities involving both hippocampi and mesial temporal lobes. The involved area appears brighter than the surrounding brain parenchyma on flare sequences. In this EEG, we can see intermittent or continuous slow waves over the temporal regions, typically in the theta or the delta range. CSF analysis commonly shows a lymphocytic pleocytosis reflecting the underlying inflammatory process. AMPA receptor antibodies can be detected in both serum and CSF, which helps confirm the diagnosis. An important feature of anti-AMPA receptor encephalitis its, is its strong association with the malignancy, with approximately 60% of patients having an underlying tumor. Most common associated cancer include lung carcinoma, breast carcinoma, thymoma. Therefore, a thorough tumor screening is mandatory in every patient diagnosed with anti-AMP receptor encephalitis. About half of these patients with anti-AMP receptor encephalitis also have associated systemic autoimmune disease. Common associations include insulin-independent diabetes mellitus with CAD antibodies, hypothyroidism, Raynaud syndrome. Factors associated with poorer prognosis include the presence of additional paraneoplastic antibodies, involvement of cytotoxic T cell mediated mechanisms, and most importantly, an underlying malignancy. In general, the patient with associated cancer tends to have more severe disease course and a higher risk of relapse. Coming to anti-LGI1 limbic encephalitis. This typically affects the older men with a median age of presentation about 60 years. Patients commonly develop memory loss, confusion, and seizures arising from temporal lobes. There are several important diagnostic clues to remember. These include hyponatremia, a brief faciobrachial dystonic seizure, which appear as very short, frequent twitching movements involving face and arm. Some patients may also develop REM sleep behavioral disorder, where they act out their dreams during the sleep. Another characteristic association is peripheral nerve hyperexcitability, which can present as Morvan syndrome. Diagnosing anti-LGI1 encephalitis can sometimes be challenging because the rapidly progressive memory problems and abnormal movements may mimic Creutzfeldt-Jakob disease, which is a rapidly progressive dementia. MRI brain often shows typical feature of limbic encephalitis, although seizures themselves can occasionally produce similar MRI changes. CSF findings are usually normal, but LGI1 antibodies are almost always detectable in the serum and are often present in CSF as well. Unlike many other autoimmune encephalitis, anti-LGI1 encephalitis has a relatively weak association with malignancy, with less than 10% of patients having an underlying tumor, which will be most commonly thymoma. Antibodies reduce specific potassium channels and AMPA receptors, causing overexcitation. The treatment and long-term outlook, about 80% of these patients respond well to immunotherapy. Despite responding to treatment, many patients are left with permanent deficit. Relapses are fairly common, occurring in about 35% of these patients. In this brain MRI obtained during the relapse, we can see the images. First image and second image showing prominent restricted diffusion and apparent diffusion coefficient correlates with the changes in bilateral basal ganglia. In third image, we can see flare hyperintensities in the same restricted diffusion distribution. In the fourth image, we can see flare normal hippocampal size. And then we can see coronal sequence showing T1 hyperintensity in the right basal ganglia. In the next image, 18 FDG PET CT, intense 18 FDG PET uptake is noted in the bilateral basal ganglia, asymmetric FDG uptake within the left medial temporal lobe. In the B images are follow-up images. These are follow-up MRI brain images of 16 months after the onset of the symptom. Axial T2 flare images are showing prominent caudal nuclei atrophy and bilateral hippocampal atrophy marked by arrowheads. Coming to anti-Casper2 encephalitis, it affects both central and peripheral nervous system. The disease is characterized by neuronal hyperexcitability because of disruption of normal potassium channel function. In the central nervous system, patient develops encephalopathy presenting with confusion, memory impairment, and behavioral changes. Cerebellar involvement can result in poor coordination and gait instability. Hallucinations and seizures are common manifestations reflecting cortical involvement. A particular characteristic feature is severe insomnia, which can be profound and disabling. Patient may also develop autonomic nervous system instability, leading to symptoms such as fluctuating blood pressure, heart rate, and excessive sweating. In the peripheral nervous system, anti-Casper2 antibodies can cause peripheral nerve hyperexcitability, resulting in symptoms such as muscle twitching, cramps, stiffness. Another important feature is allodynia, where patients experience severe pain in response to normal non-painful stimuli, such as light touch or contact with the clothing. Therefore, the coexistence of encephalopathy, severe insomnia, autonomic dysfunction, and peripheral nerve hyperexcitability should strongly raise the suspicion of anti-Casper2 encephalitis. Anti-Casper2 encephalitis is primarily mediated by IgG4 antibodies. These antibodies disrupt normal clustering of voltage-gated potassium channels at the juxtaparanodal region of the myelinated nerves, resulting in impaired potassium channel function, causing increased neuronal excitability, leading to characteristic peripheral nerve hyperexcitability seen in this condition. Morvan syndrome, it is considered the classical and the core presentation of anti-Casper2 antibody-associated disease. It is characterized by the coexistence of CNS symptoms along with peripheral nerve hyperexcitability. However, the clinical spectrum of Casper2 autoimmunity is broad. In some patients, the disease may present as isolated limbic encephalitis, with features such as memory impairment, behavioral changes, seizures, without significant peripheral nervous system involvement. This presentation is relatively uncommon. Conversely, some patients may develop isolated peripheral nerve hyperexcitability as a standalone syndrome, presenting with symptoms such as fasciculations, muscle cramps, myokymia, neuromyotonia, while lacking the prominent CNS manifestations. Thus, anti-Casper2 disease should be viewed as a spectrum ranging from isolated peripheral nerve involvement to isolated limbic system encephalitis, with Morvan syndrome representing the overlap of both the central and peripheral nervous system manifestation. Patients with anti-Casper2 encephalitis may have other autoimmune disorders, particularly myasthenia gravis associated with acetylcholine receptor or MuSK antibodies. Unlike many autoimmune encephalitis, Casper2 disease is usually not associated with cancer. However, when a tumor is present, the most common association is thymoma. Patients with thymoma are more likely to present with Morvan syndrome, rather than isolated limbic encephalitis or isolated peripheral nerve hyperexcitability. Anti-GABA A receptor encephalitis is a rare but severe autoimmune encephalitis with median age of onset around 40 years, although it can also affect children and adolescents. It typically presents as a rapidly progressive encephalopathy characterized by marked cognitive dysfunction, behavioral disturbance, reduced level of consciousness, often accompanied by variety of movement disorders. One of its hallmark feature is severe epilepsy, with nearly 90% of the patient developing highly refractory seizures, many of whom progress to status epilepticus also. CSF in anti-GABA A receptor encephalitis commonly demonstrates pleocytosis, elevated protein levels, and the presence of oligoclonal bands reflecting underlying CNS inflammation. Brain MRI often reveals characteristic pattern of multifocal cortical and subcortical hyperintensity on T2 and flare sequences. Unlike many other autoimmune encephalitis, these lesions are typically widespread and usually do not show contrast enhancement. Approximately one-third of these patients have an underlying tumor, most commonly a thymoma, making the malignancy screening an important part of this evaluation. In some cases, disease is triggered by preceding viral infection, particularly HSV1 or HHV6, and post-viral cases may also demonstrate coexisting anti-NMDA receptor antibodies. Here we can see multiple patchy hyperintense lesions involving both cerebral cortex and adjacent subcortical white matter. The lesions are usually distributed in frontal lobe, temporal lobe, parietal lobes. These lesions are often bilateral but asymmetric. This multifocal distribution is one of the hallmark of this condition. Coexisting autoimmunity and diagnostic traps. The disease mechanism is targeting GABA A receptor to relocate from synaptic to extrasynaptic site on the brain cell. Loss of these inhibitor receptors leads to hyperexcitability. Most patients carry other antibodies like anti-GAD and antithyroid peroxidase. Coming to anti-DPPX encephalitis. This is a rare autoimmune encephalitis that presents with distinct combination of severe neurological and gastrointestinal manifestations. Unlike many autoimmune encephalitis, it has a chronic, slow progressive course with symptoms evolving over several months and reaching peak severity at median age of 8 months. A characteristic feature is a prominent gastrointestinal syndrome with a severe unexplained diarrhea and a significant weight loss, occurring approximately 4 months before the onset of neurological symptoms. These early gastrointestinal manifestations often result in extensive investigation for primary GI disorders before the underlying neurological autoimmune condition is recognized by the clinician. Diagnosis should be strongly considered in patient presenting with characteristic triad of severe unexplained weight loss, progressive cognitive dysfunction, and features of CNS hyperexcitability. Cognitive impairment is often accompanied by memory deficit, confusion, behavioral changes. CNS hyperexcitability manifests by marked agitation, hallucination, myoclonus, tremors, seizures, hyperclepsia, an exaggerated startle response, hyperclepsia. Recognizing this distinctive clinical combination is crucial as early diagnosis and initiation of immunotherapy can significantly improve the outcome of this patient. CSF findings are variable and may show mild pleocytosis or the presence of oligoclonal bands, although CSF can also be completely normal. Brain MRI typically is normal and demonstrate only non-specific abnormalities, making the diagnosis heavily dependent on clinical suspicion and antibody testing. Tumor associations are uncommon, but when present, they are most frequently B-cell neoplasms. As the disease progresses, patient may develop cerebellar or brainstem dysfunction, and some cases develop a syndrome which resembles progressive encephalomyelitis with rigidity and myoclonus. So this disease is mediated by combination of IgG1 and IgG4 antibodies directed against DPPX, an auxiliary subunit of Kv4.2 potassium channel complex. Binding of these antibodies disrupts DPPX function and reduces the expression of Kv4.2 potassium channel, resulting in increased neuronal excitability and characteristic neurological manifestations. The high expression of DPPX receptors within the myenteric plexus of the gastrointestinal tract explains the prominent early symptom of diarrhea and weight loss. Most patients respond favorably to immunotherapy, including corticosteroids, IVIG, rituximab, plasma exchange. However, relapses are relatively common, and particularly during the tapering or discontinuation of immunotherapy, which emphasizes the importance of careful long-term follow-up and gradual treatment withdrawal. Coming to anti-MGLU-R5 encephalitis. This is a rare autoimmune encephalitis that typically presents as neuropsychiatric syndrome and is classically associated with Ophelia syndrome, often linked to Hodgkin's lymphoma. Many patients initially experience a viral-like prodrome with fever, headache, fatigue, followed by rapid onset of psychiatric symptoms, cognitive impairment, and memory dysfunction. As the disease progresses, patients may develop severe movement disorders, sleep disturbances, seizures, making early diagnosis prompt immunotherapy essential for the favorable outcome. CSF analysis typically shows pleocytosis, oligoclonal bands, which are less frequently detected, and MRI brain is abnormal in about half of the cases, usually showing flare hyperintensities involving the limbic and extralimbic regions. Approximately 50% of these patients have an underlying malignancy, with Hodgkin's lymphoma being the most common. The characteristic association is known as Ophelia syndrome, making the tumor screening an essential part of evaluation. Coming to anti-MGLU R1 encephalitis. This is a rare autoimmune encephalitis disorder characterized by inflammation that primarily affects the cerebellum. As a result, the hallmark clinical feature is progressive cerebellar ataxia, leading to impaired balance, coordination, and gait. Although the disease mainly involves cerebellum, some patients may develop cognitive impairment and memory disturbances. Psychiatric symptoms and seizures are less common but have been reported in a small number of cases also. Coming to anti-dopamine receptor encephalitis, this is a rare autoimmune encephalitis that predominantly affects children. It commonly presents as basal ganglia encephalitis, Sydenham chorea, and Tourette-like syndrome, with antibodies targeting the dopamine 2 receptor, leading to neuronal dysfunction. Some patients, the disorder develops after herpes simplex virus infection, and these post-viral cases often have coexisting NMDA receptor antibodies. Early recognition and prompt immunotherapy are associated with excellent prognosis, with many patients achieving a full clinical recovery. Anti-neurexin 3 alpha encephalitis. This is also a rare autoimmune encephalitis with a median age of onset around 44 years. It typically begins with a viral-like prodrome, including fever, headache, and mild gastrointestinal symptoms, followed by rapid onset of confusion, seizures, and reduced level of consciousness. Anti-Iglon 5 disease. This is a unique disorder that combines features of autoimmunity and neurodegeneration. It is characterized by sleep disturbance, movement disorders, brainstem dysfunction, making it distinct from other autoimmune encephalitis. The hallmark feature is a progressive sleep disorder, which often appears before other neurological symptoms. Patient develops severe REM and non-REM sleep abnormalities with abnormal movement and behavioral symptoms during sleep, especially in early hours at night. Many also develop sleep-related breathing disorders, including obstructive sleep apnea and vocal cord stridor. As the disease progresses, patients develop bulbar dysfunction, causing difficulty in swallowing and speech, along with gait abnormalities, chorea, oculomotor disturbance, and a cognitive decline. The clinical course is highly variable. Some patients experience a slow progression over several years, while others deteriorate rapidly and may die within few months. Unfortunately, anti-Iglon 5 disease often responds poorly to conventional treatment, contributing to overall poorer prognosis. Routine investigations are often normal in anti-Eglon-5 disease. Brain MRI, EEG, CSF analysis, EMG usually do not reveal any significant abnormality. The most important diagnostic test is video polysomnography, which demonstrates characteristic findings such as undifferentiated non-REM sleep and poor stage N2 sleep, supporting the diagnosis of anti-Eglon-5 disease. So the disease is characterized by antibody directed against IgLON5 cell adhesion molecule, Eglon5 cell adhesion molecule, predominantly of IgG4 subclass, and this is strongly associated with HLA-DRB1 1001 allele, although the exact function of Eglon5 is not fully understood. It is believed to play a role in the neuronal development and synapse formation. Treatment focuses on removing pathogenic antibodies and suppressing the immune response using immunotherapy. Most patients improve with the treatment, but recovery is often gradual and requires long-term follow-up because relapses can also occur. Anti-MOG autoimmune encephalitis is a rare autoimmune disease with the antibodies against myelin oligodendrocyte glycoprotein, which is a protein present on the outer surface of the myelin sheath in the CNS. This immune attack causes inflammation and damage to the brain, particularly the cerebral cortex, leading to symptoms such as seizure, altered consciousness, headache, and behavioral changes. It is now recognized as a distinct form from the Mogard disease and usually responds well to the immunotherapy and when diagnosed early, it will respond to the immunotherapy well. Disease occurs when MOG IgG antibodies cross the blood-brain barrier and bind to the MOG protein on the myelin sheath. This activates the immune system, including complement protein, macrophages, and T cells, resulting in inflammation and demyelination of the brain. In the cortical encephalitis, the inflammation mainly affects the cerebral cortex and sometimes the overall overlying meninges, producing seizures and encephalopathy. Although exact trigger is unknown, viral infection or other environmental factors may initiate the abnormal immune response in genetically susceptible individuals. Patients usually present with acute or subacute onset of headache, fever, confusion, altered behavior, and seizures. They may also develop reduced level of consciousness, sleep disturbance, weakness, and sensory deficit depending upon the area of the brain affected. Some patients have associated feature of MOG antibody-associated disease, such as optic neuritis causing painful vision loss, transverse myelitis causing limb weakness and bladder dysfunction, or acute disseminated encephalomyelitis. Most patients show a good recovery after corticosteroid treatment, although relapses are also common. Diagnosis is based on the clinical presentation, MRI findings, and detection of MOG IgG antibodies in the serum using a live cell-based assay, which is the gold standard test. MRI brain typically shows cortical flare hypertense lesions with or without leptomeningeal enhancement, while cerebrospinal fluid usually reveals lymphocytic phagocytosis and a mild elevated protein. EEG often demonstrates focal slowing or epileptiform discharges in patients presenting with seizures. Other causes of encephalitis such as herpes simplex virus infection, anti-NMDA receptor encephalitis, multiple sclerosis, neuromyelitis optica spectrum disorder should be excluded. Anti-glycine receptor autoimmune encephalitis. This is also a rare autoimmune neurological disorder caused by antibodies against glycine receptor, which is an inhibited neurotransmitter receptor found mainly in the brainstem and spinal cord. Glycine normally suppresses the excessive nerve activity, allowing smooth and coordinated muscle movement. When antibodies block these receptors, normal inhibition is lost, leading to excessive neuronal excitation. This condition is most commonly associated with progressive encephalomyelitis with rigidity and myoclonus, that is PERM, which is considered a part of stiff person syndrome. The antibodies bind to the receptors on inhibitor neurons, reducing glycine-mediated neurotransmission and causing neuronal hyperexcitability. As a result, the brainstem and the spinal cord becomes overactive, producing muscle rigidity, painful spasms, and exaggerated startle responses and myoclonus. In some patients, inflammation also involves cerebral cortex, limbic system, leading to encephalitis, with seizures and cognitive and behavioral disturbances. Patients usually present with progressive muscle stiffness, painful muscle spasm, exaggerated startle response, hyperclexia, myoclonus, gait difficulty, brainstem syndromes like dysphagia, abnormal eye movement. When encephalitis occurs, patients may develop seizure, confusion, memory impairment, altered behavior, hallucinations, or reduced level of consciousness. Autonomic dysfunction, including sweating, blood pressure fluctuations, and urinary retention, can also occur. The disease often progresses rapidly but responds well to the immunotherapy. The diagnosis is based on the characteristic clinical feature and the detection of anti-glycine receptor antibodies in the serum and CSF. MRI brain is often normal and may show brainstem or limbic abnormalities. While CSF may demonstrate mild lymphocytic pleocytosis and elevated protein, EEG reveals diffuse or focal slowing and epileptiform discharges in patients with seizures. EMG may show continuous motor unit activity in patients with stiffness and spasms. So here we can see summary of antibodies, typical clinical syndrome, and the key clinical clue to identify this. You can take a screenshot of this image. In this table, we can see antibody and the commonly associated tumor. Management of autoimmune encephalitis begins with prompt recognition and early initiation of immunotherapy, while simultaneously investigating an underlying cause. All the patients with suspected autoimmune encephalitis should undergo MRI brain, EEG, CSF analysis, serum and CSF neuronal antibody testing, neuropsychological assessment, and appropriate tumor screening also. The first-line immunotherapy consists of IVIG, methylprednisolone, plasma exchange. Selected patients should undergo plasma exchange based on clinical severity and contraindication for the first-line immunotherapy. Intravenous methylprednisolone is typically administered at 1 gram daily for 3 to 5 days with monthly pulse therapies, while IVIG is given at 0.4 grams per kg per day for 5 days. Plasma exchange is particularly useful in severe presentations or when the response to corticosteroid is inadequate. Patients should be reassessed after first-line therapy for objective clinical improvement. Those who improve can transition to maintenance immunotherapy, whereas patients who persistent or worsen should receive second-line treatment. The commonly used second-line treatment is rituximab, or there can be cyclophosphamide and cyclophosphamide. Cyclophosphamide is reserved for selected cases. Maintenance therapy involves gradual tapering of corticosteroids or IVIG therapy over a period of 4 to 6 months. The long-term steroid-sparing immunosuppressive agents such as azathioprine, mycophenolate mofetil, or rituximab may be used to reduce the relapse risk and maintain the remission in many cases. So, in this table, we can see the treatment modality, the induction therapy, the first line immunotherapy, and then the second line immunotherapy. We can see the treatment option, regimen to be given, followed, the route of treatment to be given, and common side effect associated with the treatment option, and the therapeutic response usually seen with that. Here we can see the alternative therapy for refractory cases, which first and second line therapy fail. The treatment options like tocilizumab or low-dose interleukin. The recommended regimen is also given here. In this table, we can see the clinical clue and likely antibody which has to be suspected associated with the clinical condition, and the tumor screening appropriately which has to be screened for. In this summarizing table, we can see autoantibody, the median age of onset of the disease, the male is to female ratio of the disease, and response, commonly how the disease responds to various immunotherapies. In this table, we can see autoimmune encephalitis subtype and the characteristic MRI findings seen. NMDA receptor often normal or mild cortical temporal abnormalities. AMPA receptor mesial temporal hyperintensities. GABA B receptor limbic encephalitis with involving hippocampi. GABA A receptor extensive multifocal cortical and subcortical flare lesions involving both gray and white matter. So in this image, we can see the decreasing order of frequency from above downwards. NMDR followed by LGI1, followed by GABA B, followed by GASPER2, followed by GABA A, GAP-MOG, glycine, AMPR, DPPX, and Eglon5. This is the decreasing order of their frequency. Common clinical presentation mentioned after that. Coming to radiological approach, here in these images we can see various color marked in the in the brain. So first one, limbic system, the color marked in the orange, the common disease associated, common antibody associated with these radiological pattern is given. The second image, extra limbic cortexes, yellow marked with the yellow color. Then third image, third color, basal ganglia, the marked with the blue associated antibodies, and the green cerebellum marked and given antibodies associated. Brainstem marked with the red and autoimmune antibodies associated with it. Spinal cord marked with the blue and autoimmune encephalitis antibodies associated with the involvement of spinal cord are also given in the table. So the take-home messages, autoimmune encephalitis is a treatable neurological emergency. It is characterized by antibodies against neuronal surface antigens. It presents with rapidly progressive neuropsychiatric symptoms. We should always test both serum and CSF for antibodies. We should not delay immunotherapy while we wait for antibody results. We should always start the immunotherapy and then wait for the antibodies. The early diagnosis leads to excellent neurological recovery in many of these patients. So early diagnosis is essential. Thank you so much.